Thank you for joining us. Today, we'll be discussing healthcare transformation, the shift from volume to value, and specifically, finding the upside opportunities so that healthcare organizations can survive the sea of change under the Affordable Health Care Act. Now we're on to our second panelist, Kim Pardini-Kiely.
Great.
Kim, we just left off on quality metrics. We all know that quality is the name of the game in healthcare transformation, but it's not an easy thing to overcome, as we heard from both Dr. Billingham and Dr. Calhoun. Right. Can you please tell us how we can overcome those challenges?
Sure. I think, to start off, the whole idea around integration means you have to know how well you're doing in order to be able to integrate. And at a time where there's a tremendous amount of innovation going on, both on the delivery side, there's an equal amount going on the payment side, or more importantly these days, around value, right? So we're in this space now of moving from really pay for reporting to pay for performance. And this whole business of creating value is incredibly important so that we know that we're all headed in the right direction. In order to really be able to demonstrate value, you have to have good systems in place that allow you to measure outcomes, allow you to measure processes, and then you've got to be able to turn that analysis into actions that actually work across broad groups, whether that is hospitals and systems, or whether it is across a system. But in every single way, people have to start working together in order to get to the right outcomes. And there's vertical integration and there's horizontal integration when you think about quality. So when I think about vertical integration, it's that you have to be all in at the executive level, right? You really have to be able to spell out for your organization what it is that is important for you to survive and thrive in this new environment. And you have to have frontline clinical involvement. So that integration that happens vertically is very, very important. The horizontal piece is that there have to be systems to support all of that to go on, right? Because it doesn't just happen initiative after initiative. It has to be really well coordinated. So one of the things that I wanted to just kind of broach is this whole idea about, so how do you do that in an organization? How do you move beyond just measuring and reporting on quality to actually getting to the point where you're improving outcomes? Because the way that you're going to do that is going to be changing practice. And that change of practice is not an easy thing for all of us to kind of wrap our heads around. So in order to do that, you need not only to have improvement efforts going on, but you have to have a management system that supports the activities on a daily basis. And that's one of the things that is pointed out on this slide. A really good system, a good operational system, has both of those two elements. And when you start thinking about what those two elements, the first piece is that the management system has to support those activities, right? You can say, this is what we want to deliver, but if you don't have operations that support you to deliver it accurately every single time, you're not going to be able to get there. So when we think about what healthcare has been addressing, we all know we're trying to get to zero harm. We all know we're trying to improve performance around things like core measures and all of the mandatory reporting that's going on right now. So you can do it initiative by initiative, but that management system is really important. On the improvement side of the house, you can use any kind of methodologies, right? You can use lean, which I think we've seen a growing desire to kind of use some of the tools that have been proven certainly effective in manufacturing, but you're going to have to do it based upon the healthcare system, so you'll have to tweak it a little bit. But that improvement side really helps drive the outcomes you want with a management system that supports it underneath.
So the operation system that you talked about, I'm just trying to analogize it. We've got the vertical leadership and the horizontal leadership, and the operating system is sort of the glue to all of that to make sure it all happens.
Exactly.
Now, when you mention an operational system, in my mind, I'm thinking something I can buy. Can you please give us an example of the operating system that you're referring to specifically?
So an operating system is really the context, or it is the description of how you do your work. So when I think about an operating system, the elements I mean, you really do need to define who does what and how do they do it. So really coming up with things like standard processes. You know, that's part of minimizing variation in practice, is really being very clear what you expect to happen. And then being able to monitor and measure against that to make sure that, in fact, people are doing the right things at the right time. And if they're not, why aren't they? Because when you really get to the front line and you ask those questions, you come up with a lot of ideas and a lot of answers that you can really then iterate on your processes to improve performance.
And this question's open to Ron. Ron, you have a lot of different clients. Have you seen a lot of the clients within the ACO structure and non-ACO structure actually implementing operating systems to make sure that they have these systems in place to overcome the whole quality challenge?
That's a very good question, and unfortunately that has not been consistent. And I would say that probably a majority of the ACOs that are operating right now are not fully clinically integrated. And we could probably go around the table and have, if you were to ask us to define clinical integration, we probably would have dramatically different answers, but I think they'd be converging circles. I see a lot of attention to organizational structure, to leadership. What I see missing is that dirty, grimy work of narrowing physician practice pattern variation. And that takes a unique combination of non-clinical and clinical leadership to accomplish. And I think that's the next phase that we're going into. Yeah. We've kind of done some, the heavy lifting as it relates to the organizational design, the appropriate blend of physician and non-physician leadership. Now we're getting to the point where we really have to take variation out of the equation. One of the fundamental problems actually is the fact that about 73% of all of our platforms across the country are still fundamentally on a fee-for-service model. Although we are making, the velocity of change as it relates to payment transformation is pretty great. But when you think about clinically integrating in the face of that dynamic, you're taking unnecessary utilization out of the system, you're still on a fee-for-service platform, and you're doing that against your own self-interest because your revenue is going to reflect that. So that's another fundamental, I think, unspoken barrier to kind of breaking through the next layer of clinical integration.
It's hard to do all of the clinical integration and the innovation on just the delivery side.
Right.
There has to be the equal match around the reimbursement side if we're ever going to get it together. And those two coming together is hopefully going to be the sweet spot where we can come up with, and albeit a variety of models, but clearly defined models that we don't currently have.
That coordination is so important, yet people just can't get their arms around it. So I'm glad that you provided some helpful advice to our audience today. I'm picking up on Ron's comments regarding physicians and other leadership not getting their hands dirty. As a physician yourself and a physician leader, what's your perspective when it comes down to the leadership of healthcare organizations today? Because we all know it's the leadership that needs to move the needle, yet at the same time, Kim made a comment that frontline leadership is also equally important.
Again, a great question, and I think what both my colleagues were alluding to is that the traditional medical decision-making platform and hierarchy is getting completely disrupted as part of this change. How do you narrow behavior either organizationally or clinically? Well, in the old days, fear and money seemed to be
pretty effective.
Pretty effective. But I think that's gone, and other traditional methodologies. For example, in large healthcare systems, for example, a friend of mine calls it BOGSAT LGW. Bunch of guys sitting at a table, loudest guy wins. Yeah. And I think that those methodologies are gone, and you are going to have true integration means that everybody's going to have a seat at the table. So the way I see this is that if you're the CEO of the organization, your job is to articulate a vision that people can get behind and create an environment that lets frontline innovation succeed. Yeah. Because the people that are actually, it's that, you mentioned lean, but it's the ability to stop the assembly line of healthcare when somebody has a great idea on the front. And those organizations that can implement that change and do it well, they will be successful. If you're hanging on to those silos of the past, I think we're going to see flattening both vertically and horizontally. Let me give you an example. and also how we can learn from other industry. Quick healthcare example. A friend of mine is the VPMA of a large healthcare system, was sitting in a room with 10 other physicians, and they were in the process of credentialing a lot of PAs that were coming into the system. And midway through it, he realized that we didn't, as physicians, we weren't aware of the training. We didn't understand, some of the scope of practice issues. We didn't understand, some of the technical components. And he suddenly thought, well, why isn't there a PA or an NP, which are going to be 50% of the workforce going forward, having a seat at the table so we can truly integrate and learn? And that's exactly what they did. So he changed the paradigm, put them at the table, and the physicians learned a tremendous amount, and also established both transparency and a collaborative workforce. And I think it's not lost on anybody that in the Silicon Valley, the 50 miles that surround where we're sitting right now, a lot of hospital CEOs are not sitting in private, closed offices with the door shut. They're sitting out amongst their workforce, and the best ones are listening.
May I tag on to that?
Absolutely.
Yep, I don't want to take us off course, but I'm reminded of an experience that we had in, names removed, in a Midwestern state, large employer, high concentration of employees. And we asked the question, when was the last time that the primary integrated delivery system that these employees are being steered to through their plan design, when was the last time they met with them? And their answer was, we've never met with them. And we met with that integrated delivery system and asked the CEO the question, when was the last time you met with this employer? 7,000 lives being steered into your facility that never met. There's another fundamental problem, is this disengagement from the recognition of who the customer is, because of the historical just kind of acquiescing of that responsibility to the payer. And that's going to fundamentally change as well.
That's interesting, because you would think that the paradigm shift would actually rechange the focus of the culture, the way that physicians, I'm using them as an example, would change, and they're just not doing that. So can we talk a little bit about how we can find a sweet spot for culture, leadership culture?
Yeah, when you think about it, exactly what Dr. Billingham described that is required of the CEO. So it's really, we're now asking a CEO to provide leadership internally to allow clinical integration to occur, and to engage with a new customer that they historically, as a rule, have not really been engaged with. So that really is a totally new dynamic in terms of the leadership skills of the CEO.
And it's not something that was taught. I mean, coming up through the clinical process, we were always pegged and put out front as captains of the ship.
Right.
We weren't taught team-based training.
Right.
And so I think the younger physicians coming out will be far more geared to that, and the rest of us are adopting to this change.
Right. Yeah, although that will have to be very purposeful, right? Because even now, training in medical school doesn't necessarily focus as much as it should on teamwork, and it doesn't in some of the other disciplines as well. So we're talking about nurses and respiratory therapists, and so if you think about clinical integration, really that key and some of the sweet spot is teaching them to function as a team and how to communicate as a team. And many of our systems don't necessarily allow them to be able to communicate in real time so that they can be more effective. But I think to your point about, the importance of clinician-led improvement and clinician-led processes is what is critical. It's not going to happen in a committee. A quality committee is not where things are going to change. It's going to be getting out there and really asking for that frontline input so that you can really design your models to be able to support the best outcomes.
Since we're on team-based training, Kim, in your experience, you were the Vice President of Quality and Effectiveness.
Yeah.
Can you share some of the success stories with respect to either cultural change or team-based training?
Sure. So, one of the things that we did that was just phenomenally successful was what we called in-situ simulation. And in-situ simulation, in-situ, some people say as well, is really about teaching people to be functional members of a team in their environment, which is different than taking people off-site and going to a simulation center. So we found that when we actually, held a patient room and did simulations in the room, on the units where everybody practices, and pulled people into it and then went through a scenario and then debriefed at the end, the learnings were tremendous. And everybody's perspective was brought forward that they didn't normally do. So after an event happens, everybody goes their merry way, and this really allows people to learn on the, in the real world about how do you more effectively communicate. And I do think that teamwork is going to be key for us because it is such a complex environment.
Dr. Billingham, what kind of work have you seen with respect to team-based training?
Well, more and more. I mean, obviously, even though there's such a grind to get through the medical school process, we are taking the time to teach, particularly the young physicians and residents. So things like sign-offs, things like a handoff process, particularly, at the end of shift, where there's more communication, and everybody is empowered to speak up. And disrupting what may have been, traditional communication processes in the past. We're going to flatten the hierarchy. It is too complex not to do that, and particularly when you talk about not only achieving efficiencies, but also patient safety initiatives. Everybody's got to be empowered to say, "Oh, stop! Can we take a look at this again?" And I think that's happening, but this is going to take time. This is not going to happen. It's change in healthcare is hard on everybody, and it's going to take some time.
Do you see we all see a lot about evidence-based, and the reality is, in the Medicare population alone, evidence-based medicine is practiced about 9% of the time. So do you see the team-based efforts being a vehicle to, we hear much less about clinical best practices and a lot more about clinical integration. And so these clinical best practices are not evidence-based, obviously, but should be equally as embraced. But do you think that evidence-based gets more press than it should, in almost to the exclusion of getting more clinical best practices established?
Well, I think what we struggle with is that there's not always good evidence for many of the things that we do. So, I mean, we really struggle with, how accurate is the evidence and what can we base some of our practices on? And at the same time, there's so many nuances in the practice of, medicine, not only for physicians, but for nurses as well, which is about a communication with the patient and kind of evaluating that. So I think evidence needs to continue to inform us and to set the standards where we have it. And I think the other piece is that we have to be nimble when it comes to evidence, because evidence is also changing, very rapidly. And so we don't want to, put in a practice that, then changes and not allow that change to happen. So that nimbleness, I think, is critical.
Yeah, I want to just follow up on that and say, there are campaigns and efforts to do, Ron, exactly what you said, which is to not only make best practices or evidence-based guidelines, but also in a most cost-effective platform as well. Campaigns like Choosing Wisely. Well, there's a big discussion going on right now because of so much of the cost on defensive practice and defensive medicine in the United States, which is understand that this is evidence-based literature and that this is the smart thing to do. Understand that this is the least expensive and most cost-effective. But we didn't really have the discussion about it. If you do that, did it come with safe harbors or some sort of tort protection? So I think that's one of the barriers to rapid adoption, how you change people's behavior, which is if we do use these clinical practices and there is a bad outcome, will there be some tort relief?
Right.
That's the downside. I'm going to try and keep it light and on the upside. But thank you very much, Dr. Billing. I do want to swing back to you, Kim. You talked about public reporting, and we know that public reporting is getting bigger and there's more regulation. So I just would like for the audience to understand how public reporting is actually going to increase quality of care.
Well, let's face it. Now that we're into the pay-for-performance world, you really have an obligation to continually improve. So the public reporting has really made visible the things that providers and healthcare systems should be providing in terms of delivery. It's that nimbleness that I talked about that I think is a little bit of the Achilles heel. Are we always measuring the right things? But to be honest, firm belief that this move towards public reporting has been, in large part, a really good thing for improving patient care.
I'm going to take a little detour with public reporting, and I'd like all of your opinion on this. Transparency in healthcare is huge. We have transparency in healthcare with respect to disclosing medical errors, and now we're going to transparency with respect to quality metrics as well as pricing. So is a sweet spot an opportunity to perhaps take this transparency reporting and focus it on a particular group? So I'm going to use the young folks. The young folks are highly wired in. They're spending their money in certain ways, and they want to keep and protect their money, and they're easily able to potentially in the future download certain apps that are going to display quality metrics, pricing, a variety of physicians and services around the country. I'm going to start with our physician expert first, and wanted to get your thoughts on that as a strategy for some organizations.
Well, I think in terms of the ability for delivering care that's cost effective, we're all going to have to get a lot better educated on those choices. And I would translate what you just said, as sometimes I get pushed back into, gee, Graham, don't talk to me about cookbook medicine, because medicine, in fact, is an art and a science. And it is, and what I would say is, that's great for these 90 chief complaints, but for these 10, maybe we could sit at a table and have some consensus on and structure them, the delivery of it, to ensure that we have the best data, we have the best guidelines, and that we narrow practice variation for potentially high-risk diagnoses.
I would like to add to that with with a bit of a twist. If you were to kind of visualize an axis that varies by low acuity to high acuity, and then another axis, and that's a horizontal axis, and then a vertical axis that varies by anonymity and an intimate relationship with the patient. This lower, I'm reversing here, this lower left quadrant, anonymous, low acuity, there's major transformation going on in that basic care box. And it's a box that acute care has not really done a very good job reaching out into. That acute care is in that upper right, where you've got higher levels of acuity and an intimate relationship with the patient. The lower right is the ER, basically, higher levels of acuity, anonymity. So I think a big challenge is going to be how is acute care, particularly in the context of population management, going to effectively reach into that lower acuity anonymous box. And I think that there's a lot, because that box actually populates out to be bigger than the other three combined. And you've got a lot of disruptive models that are emerging out there that are very effectively attaching into that box. What made me think about that was your description of the younger demographic that are used to consuming things differently. And I think that is a major transformation external to the four walls of the acute care facility that needs to occur, that quite frankly, we're not seeing a lot of. They're outliers. Geisinger does a fabulous job. Spectrum Health with their community outreach program, Banner with their MedSeek patient engagement strategy. But engaging a patient before they actually become a high acuity patient is going to be critical in population management, and that is an area that I think needs